We will be recording all this yet again and taking notes to make sure we capture all of your thoughts and comments. And so please feel free to speak up. And also, we will have a mechanism in place to let you tell us about other questions that you may have thought of. So I'm now going to introduce Tony Crispino and let him give you a little more thought about this.
Thank you, Mike. First off, I wanted to touch a little bit on support advocacy and research advocacy. As an advocate, I have seen through the years many questions asked about active surveillance. And what I've learned is that there's not a lot of answers provided through high-level investigation or research. Support advocacy, clinical trials were basically looked at when I started out as for patients to find a cure for their disease. And when I went into research advocacy, I came to understand that clinical trials are designed to answer a question. And this is a really key point about why we're assembled here as a group and how to present new research questions to be able to get those answers, because if you don't ask the questions, they don't get answered. I remember in 2012 and attending ASCO, Oliver Sartor, renowned oncologist out of Tulane University, brought up the point that we have abundantly clear information on what to do with advanced prostate cancer patients and guys who are with high risk. But we were abundantly short on information what to do with patients with low risk and very low risk disease. And that rang true when I went into guideline advocacy, when we were writing guidelines. And in writing guidelines, the level of data was much stronger on what to do with advanced prostate cancer patients and patients who required therapy. And the level of data would be listed as strong, and it would be evidence recommendation strong. When we got to active surveillance, it came back to expert opinion, which was kind of on the low end of research. Where this leads us and where I'm leading this to is that we have learned a great deal from the United States Preventive Services Task Force Grade D recommendation to recommend against all screening for prostate cancer. And that was based upon overtreatment and overdiagnosis, and more conservative management was necessary. And that's what you guys are, the experts in conservative management. You guys are the experts who have been going on out and looking for ways to deal with your prostate cancer and to make your experience stronger by looking at different unscientific documents or documents that did not raise to the level of evidence that is needed to get a guideline forward to go ahead and say, this is how we should do active surveillance. I take my hat off to everybody in this group that participated in this, because you are making a difference in this. You are absolutely providing the questions that are necessary to get to better research and to get to better guidelines written down the road, provided from that research, that will lead to the future of active surveillance in patients well beyond yourselves. And I applaud that. And I also want to thank you guys for making me a better patient advocate by being very open about your opinions and being very straightforward and about your commitment and your education levels. You guys have all learned, and this is kind of an advantage for people on active surveillance. You get the opportunity to learn more about the disease because you'll live with the disease probably the longest of all the groups within the risk groups of prostate cancer. So again, I take my hat off on that. And I can tell you that from what I've been seeing in the questions asked in this group, many very valuable questions are going to be brought forward, and they will be utilized to create a better experience overall. Again, thank you. Back to you, Dr. Siddiqui.
Great, thank you very much. It's my pleasure to now introduce Peter Pinto. Peter Pinto is a principal investigator and senior surgeon, head of prostate cancer section, and fellowship director at the Urologic Oncology branch at the Cancer Institute at the National Institutes of Health. He's nationally and internationally recognized as an expert in the field of prostate cancer and image guidance to improve active surveillance, focal therapy, and robotic surgery. He holds multiple patents in the novel methods and systems of performing image-guided biopsies, and was a co-creator of the UroNav MRI transrectal ultrasound fusion prostate biopsy system. He also has a robust clinical practice in the management of localized and locally advanced prostate cancer. And his translational research interests include vaccine strategies and molecular target therapies. So he really spans the spectrum of everything we're talking about and beyond. It's been my pleasure to work with Peter for now over 9 years, because I did my fellowship with him, and it's, he's just really a major force in our field. So we're honored to have him today. He's going to be talking about what is new and emerging in prostate cancer and active surveillance.
Great day on Monday. I'm going to try to tie in some of the themes of the group discussions into today's talk, looking at the emerging and new opportunities in prostate cancer surveillance. For full disclosure, I'm a U.S. federal employee, urologic surgeon scientist. We have a lab in conjunction with Philips Healthcare developed the URINAV biopsy platform. I'm speaking here because the work we've done is truly a we. This team is amazing, been with me for many years. I want to highlight them. Baris Turkbay, Peter Troiki, our radiology colleagues, Maria Marino, our GU pathologist, Howard Parnes, who you spoke on Monday, and you heard how wonderful and knowledgeable he is in this field. Brad Wood, our interventional oncologist and device colleague, and of course, all the medical students that work in my lab for a year and go on to urology, all the DC urology residents that rotate through the NIH, and all the fellows we get over the years who, many of them focus on prostate cancer, active surveillance, image guidance, and have great careers. Minhaj, for example, Arvin, and we have our current fellows, 2 of them here, Michael Rothberg and Zach Kozil, helping out this program. I want to thank them all. So opportunities for surveillance, I wanted to break it down into a couple of categories. How do we expand eligibility for men on surveillance, get them more involved, and keep them on surveillance? How do we decrease the physical and the mental morbidity of active surveillance? And how do we provide treatment opportunities to coincide with surveillance? Many years ago we coined this term super active surveillance, combining focal therapy and active surveillance. But other modalities, drugs, prevention, how can we pursue those? So let's start with expanding the eligibility for men on surveillance. How do we expand? Well, first of all, historically, some of the first active surveillance opportunities were for the older men with short life expectancy and comorbidities. Well, how do we unfeather us from that, get into the younger population of men, maybe the healthier patients of men who can go on surveillance but are not as ill as first prescribed? Well, what about opportunities for increasing from low or very low to intermediate, favorable, maybe unfavorable intermediate? How do we expand that opportunity? And then I think very important, and we'll discuss in a little more detail, how do we, even for the low volume, low grade, low risk patient, how do we have that person feel confident to go into surveillance? And how do we have the urologist or physician feel confident in offering surveillance to that patient? Well, one opportunity with novel imaging, and there's opportunities. Of course, we know about MRI, but there's new modalities in ultrasound. There's metabolic imaging. There's artificial intelligence wrapped into novel imaging. These are all potential questions and trial opportunities going forward in the future. What about maybe assessing the biological potential of the tumor, going beyond Gleason grade? What about kind of tailoring based on the germline status or the somatic mutation of the tumor status to decide who should go on surveillance and who can stay on surveillance longer? What about commercially available biomarkers, blood, urine, or tissue markers? And of course, what about using the power of AI to understand the eligibility and possible progression onto beyond surveillance for these patients into a higher risk category over time, and can we model that? So these are all opportunities to study to maybe enrich the population of patients who can go on surveillance. We'll start with imaging and focus on that for now. I'll leave with an example. This is a patient I saw many years ago, 57, PSA about 4, had a systematic 12-core biopsy, found one core of the 12, 5% of that core was cancer. It was all grade group 1, and appropriately was offered surveillance, of course nerve sparing for his surgery, or if radiation, a small gland and brachytherapy seemed to be the least morbid for the patient. Of course, surveillance opportunities like this exist and they look great on paper, but there was some hesitancy by the patient and the physician and said, well, maybe we should do a confirmatory biopsy. Maybe there's something more ominous. There's a program at the NIH. I want you to see Peter Pinto. Maybe we can get an MRI and see what's going on. And sure enough, that's why this is a case being presented today. That large tumor at the tip of the arrow was on MR visible. And our radiology colleagues said, listen, not only is this highly suspicious for cancer, highly suspicious, PIRATS 5, but, on the assumption it's a cancer, it has gone through the capsule into the left neurovascular bundle. So, of course, we do an MR targeted biopsy of this area, and we confirmed this was grade group 4 Gleason 8 cancer. And therefore, without the MRI, that uncertainty, that uneasiness about a bigger tumor was really kind of a premonition of what was going to happen. The surveillance opportunities were there based on the information, but it was not accurate. And with MRI, what we obviously found is he was staged more accurately, the T3A, not T1C, in regards to clinical stage based on the imaging because of the tumor beyond the capsule. Gleason 8 cancer, and of course surveillance no longer an option. Of these choices he had, which was radiation with concurrent ADT, or surgery where we're going to modify and remove that nerve, he chose for surgery. Pathologically, you can see here that on the left side of the screen, we came very close. This is the right side of the prostate where there's no tumor. And then right about 6 o'clock position, we took extra tissue around, took out the nerve where that tumor was beyond the capsule based on the imaging. And on higher magnification, you can see the tumor was beyond into the nerve, but the ink margin was clean. This patient's almost now about 9 years out, and with no adjuvant therapy, based on his clean margin, PSA remained undetectable, and he's maintained a good quality of life for now. So, this uncertainty of the traditional biopsy, will provide a hesitant patient to go onto surveillance, and the physician too, and you can't blame them because these anecdotal cases I just showed kind of stick in the mind of the physician, and we always quote that important journal, the Journal of Anecdotal Cases. So, how do we kind of, improve that? Well, we published a paper last year looking at this. This was a trial where we had 2,000 patients who in one setting either had an MR fusion targeted biopsy or that blind systematic biopsy 12 core, and in both biopsies, one setting, we took the data from both biopsy techniques. We call that combined, and we'll focus on today just those 404 men who went to surgery. Let's look at the upgrading event and see if we can improve upon that. So, for those who don't know, this work has other certainty. The certainty is that we know when we do rad path correlation, the axial image on the MRI is the same image on whole mount because we have a mold where we slice the prostate as directed by the MR slices. So we have, stringent correlation between those areas. Well, the upgrading event on systematic biopsy, about 30%. This is upgrading to grade group 2 or higher, consistent with what has been published before in the literature. With the MR target, so when we look at the MR fusion biopsies and just analyze that in the upgrading event, we're down to about 18%, but still almost 1 in 5 patients will have upgrading from their MR targeted biopsy. But when you take the data from the MR targeted biopsy and the systematic biopsy, the upgrading event drops to 6.7%. So now you have a little more confidence that with a complete biopsy, MR targeted and systematic, we call that combined biopsy, that you're not missing other cancers. And therefore, that's an assurance to the patient and the physician that no higher grade was missed. And therefore, if you are low grade risk or favorable intermediate, it's very, very unlikely you'll have anything worse with this technique of a biopsy, and therefore you can go on to surveillance. So we discussed eligibility to enroll for surveillance. Now, I know we're running out of time here, but decreasing the physical and mental morbidity of surveillance, that means maybe decreasing the number of biopsy sessions over a lifetime, especially if a younger patient, we often hear, well, he's too young for surveillance, he'll be biopsied and imaged his entire life, could be 30, 40 years. What if we can decrease the frequency, have questions around that, trials to answer those questions, or decrease number of biopsies, focus on just the tumor once we know he's on surveillance, and how to combine biopsy. And then I'll end with the last few moments about treatments to coincide surveillance. We always would love to have a diet or lifestyle change to keep a person's cancer, I would say, stable on surveillance. What about drugs or devices going forward? Well, for focal therapy, what if we have a single lesion on surveillance, MR visible, and that patient just feels comfortable, is afraid it may progress? Why can't we treat it focally, either with cryo, freezing, some other device, and then still keep them on surveillance because we'll follow the rest of the prostate and that area of treatment, a term we coined super active surveillance. What about the drugs? We know about the ENACT trial, phase 2 open label study. Neil Shore, of course, kind of a leader in this field of large phase 2 or phase 3 trials. So it's ENZA in people on surveillance versus surveillance by itself. Not for very low risk patients, but for low risk or intermediate risk. This was full dose ENZA, 160 milligrams a day for a year, followed up up to about 3 years, looking at time to cancer progression or time to treatment, and then the incidence of negative biopsy at 1 and 2 years, and also assessments for quality of life and other measures. They had enrollment about 50-50 low risk and intermediate risk patients. And you can see from this chart, 114 patients in each arm. And, there was an improvement in time to progression. There was an improvement in the negative biopsy at 1 year. But, that kind of went away at 2 years. And the AEs were significant, 92% of patients versus 54 or 55% for the placebo group, for the non-drug group. And you had fatigue, gynecomastia, nipple pain, breast tenderness. These are things that maybe on surveillance a person wouldn't be interested in pursuing. But still, excited to see this opportunity of adding a drug to surveillance. We don't have data yet for this, but the PROVENT trial, looking at autologous cellular immunotherapy as an adjunct with surveillance. There was, again, similar outcomes. There was a report of this by Ashley Ross. Again, Neil Shore leading this work, looking at some of the product parameters, upregulation of the immunological markers as compared to their same drug given to metastatic prostate cancer patients in their IMPACT trial. And interestingly, they saw a more potent effect of CYP-T on men on surveillance. So, we'll get the results when they come out, but it seems to be intriguing. This could help us a little bit. All right, thank you very much.
So our next speaker is Dr. Erika Johnson from Sweden. She's at Linköping University in Sweden. And for those of you who don't know where Linköping is, it's roughly in the middle of the south of Sweden, between Gothenburg on one side and Stockholm on the other. Dr. Johnson has recently been studying what one might think of as the sociobiology of prostate cancer, how we all think about it, how we all react to a diagnosis, how we all react to the level of that diagnosis. And so she's going to be talking about this, but also in the context of how women have also got involved in healthcare history, because they are way ahead of us in many ways. And there are some analogies that are worth thinking about hard.
My name is Erika Johnson, and I'm a professor of gender and society at Linköping University in Sweden. Today, I'm going to talk a little bit about women's health activism and some of the lessons that it may have to share with those who are concerned about prostate health. I teach about women's healthcare activism in some of my classes as part of my job. But for the last 7 years, I've also been leading a medical humanities research project about the aging prostate, studying how prostate health is entangled with social understandings of men and masculinity and sexuality and aging. The project engaged 9 researchers from fields as diverse as anthropology, history, sociology, sexology, organization studies, science and technology studies, and also gender studies. We intentionally did not include medical doctors because we wanted to look at other aspects of prostate health, Here is a list of the colleagues that participated with me in the research and a picture of the book where we present our results. One thing that many of us had in common when we started this research was an academic background in gender studies and feminist theory. I think it is a common misconception that gender studies and feminist theory are only interested in women. But for us, these theoretical perspectives provide tools to understand how society produces knowledge and how it disciplines bodies. They give us the ability to see where change could make an improvement for people. I illustrate this slide with a generic public restroom sign for two reasons. One, it is a clear example of how gender categories discipline bodies. Our gender categories tell which bodies where they can go and where they can't go, where they are allowed to be. But also because the public toilet infrastructure has long been a contested site for feminist activism, disability activism, and also trans and non-binary activism. And because we saw really clearly in our research that the public toilet infrastructure was not always meeting the needs of men with prostate health issues. I suggest that this could be a first example of how prostate health could take a page from feminist health activism. When they work well, we encounter public toilet infrastructures that have been changed over the decades to accommodate bodies in wheelchairs or with other mobility needs, that provide sufficient numbers of toilets for women, that are accessible to baby strollers or that have diaper changing facilities, and in some cases, which also accommodate bodies that are not cisgendered. But in the interviews we conducted, we realized that men with aging prostates were not always having their needs met by the public toilets and public toilet infrastructures that they were embedded in. So one suggestion would be to think through questions like, where are the bathrooms? Are there bathrooms on public transportation? How many are there? How does one find them? So for example, this app up here in the picture, in the slide, is from, the picture is from an app over the City of London that tells where public toilets are and ranks them and gives some descriptions about them. And these types of apps have, in many cases, been put together for cities with support from prostate cancer patient survivor groups. One can also ask about the toilets themselves. Do they have stalls with doors, or is it just a long row of urinals? Are they clean? Would a person feel comfortable changing a catheter in them? Does each stall have a place to dispose of urinary incontinence pads, for example? Is the built environment meeting the needs of the bodies that need to use it? Does the world fit our needs? One lesson from feminist theory is that the built environment tends to be built for young, healthy male bodies from certain privileged positions, and that their needs are what have traditionally been behind architectural decisions. That is why in older buildings, one can see long lines outside of the women's room while the men's room is half empty. But prostate problems are seldom part of the imaginary involved in that type of urban planning, and activism might be needed to articulate the needs of those with prostate issues. Another site of possible inspiration comes from feminist activism about women's health that has been ongoing since the 1970s. Here I am referring to women's collectives which initially criticized the kind of healthcare that doctors were providing back in the middle of the last century. These activist groups, like for example, the Women's Boston Health Book Collective, gathered lay knowledge about women's bodies, gathered the women's knowledge themselves about their bodies, and published it, like in the book, Our Bodies, Ourselves. They also demanded that healthcare be changed to meet women's needs. This brought about everything from better access to birth control, recognition of female sexuality, and a reduction of unnecessary gynecological surgeries for individual women. It also agitated for the inclusion of female bodies in medical testing and diagnostic practices, which addressed things like women's heart attacks not being recognized or treated properly, or there being too little knowledge about how female bodies responded to new medications. On a theoretical level, this type of activism challenged medical expertise by claiming that the patient's knowledge of their body was and is valuable. It also questioned research materials and approaches and demanded that medical science include women's needs and desires. And it demanded care that respects one's lifestyle, that would allow women to use their bodies to live the way they want to, even after treatment. I think those of you gathered here today can clearly see how these concerns are relevant to prostate health. You know your body. You know what kind of research questions should be included in future medical research, and you know what you want to do with your body, even after treatment. And a meeting like this is one of the ways to get that knowledge heard. A third tip from women's health activism is the lesson that we learned and are still learning, that not all women are the same. The category woman is simply too broad and too heterogeneous to be useful analytically or politically, and so is the category men. It needs to be used in a way that opens for and respects diversity. With our research in prostate health, we saw this very clearly, especially in recognizing that sexual identities and practices vary, both before and after prostate treatments. Living situations vary, including things like partners and relationships, but also expectations about a man's role in the world and his own expectations about his ability to move through it. And that intersectional categories are important, like age, health, geographical location, sexuality, gender, class, and race, and that these have an impact on healthcare access and healthcare needs. Being able to recognize and action these different aspects of identity, which have very different impacts on a patient's power in the clinical encounter, can produce more generative conversations about healthcare needs, and probably also produce more useful healthcare activism. So finally, just to summarize, 3 places where women's healthcare activism could be inspiring to prostate health may be in making efforts to change the built environment, perhaps through building alliances with those working in urban planning and norm creative design or in architecture, challenging medicine, which is sometimes called the epistemological critique, and means demanding medical practitioners listen to patients' voices, like you're doing today, and demanding recognition for diverse needs, which involves what is often called the intersectional approach, and recognizes how we are all differently positioned along social axes of power. So I hope these slides can be inspiring for your continued conversations and efforts, and thank you for inviting me to speak with you today.
Thank you, Dr. Johnson. Minhaj, back to you.
Okay, wonderful, thank you. So we are going to now transition into a very exciting phase, and the goal now is to actually review the results from day 1. So in the background between Monday and today, there's been a lot of work with a group of people who've been coming together to really analyze all the conversation that took place on Monday and capture it into essentially questions and summarize it. And so ultimately, through those efforts, we were able to generate 22 questions, and those questions were able to be divided into 4 groups. So you would notice if you've been seeing some of the kind of draft agendas that were circulated earlier for day 2, you'll notice that the agenda changed a little bit because it became clear that the groupings had to change somewhat. but we believe we were able to kind of capture the majority of the message that we were being told through these 4 groups. And again, just like Mike said, kind of at the beginning of all this may not capture every single topic that was discussed, but in the space of trying to develop comparative effectiveness research questions, we believe we captured a lot of the topics. You know, like we said in the opening, not every good topic is a good research topic, but the ones that can be researched from a comparative effectiveness structure, we are hoping that we captured a lot of those today. But this is where we get your feedback to make sure we did. And so we will we will first run through and present to you all the 22 questions and develop into the 4 groups, and then we will discuss kind of how we're going to spend the rest of the day. So off to Arvin now for the first group.
All right, thank you, Dr. Suzuki. So we're going to be focusing on questions that are related to interventions that can affect the cancer outcomes in active surveillance. So I'd like to thank everybody from our prior sessions for participating and giving your feedback. And so we're going to look at some of the questions that we helped refine based on that and looking for additional input. So in this first question is, in the population of men with Gleason grade group 2 prostate cancer, MRI visible lesions on active surveillance, does focal therapy or focal ablation followed by continued surveillance compared to continued active surveillance impact presence of grade group 3, because this is we talked about this as the kind of the progression endpoint on surveillance biopsy, and secondary outcomes looking at progression to definitive treatment. If you ultimately undergo definitive treatment, is there changes, are there different incidences of adverse pathology, and certainly looking at quality of life measures and the traditional measures of metastasis-free survival, depending on the length of the study. The timing was 1 to 3 years. Obviously, there are some endpoints which we would not be able to achieve within that time frame. And then the setting would be centers with experience in both AS and focal therapy. The goal of this question was to really integrate one of the themes, which was, are there things that can be done to be able to remain on active surveillance for a longer period of time? And this reflects a little bit of what Dr. Pinto was talking about previously, as he described it as quote unquote, super active surveillance. Next is a similar patient population, again, Gleason grade group 2, with greater than 5 millimeters of pattern 4 or cribriform histology. Can you, well, the intervention would be immediate treatment versus continued active surveillance. There's some uncertainty with regards to cribriform and intraductal histology potentially being more aggressive. And so the outcome would be adverse pathology on radical prostatectomy, biochemical recurrence-free survival, those who had the intervention, and ultimately the need for definitive treatment in those who are definitive treatment or metastasis, ADT or whatever it is of those who remained on surveillance. Timing 5 to 10 years, essentially amongst all centers. This question is in men with favorable intermediate risk prostate cancer. Are there novel therapeutics such as darolutamide, apalutamide, in conjunction with active surveillance versus active surveillance alone? And the outcome would be reclassification or transition to definitive treatment, outcomes, adverse pathology, and again, similar to what we described before, metastasis-free survival, and the timing would be 5 years. This is, again, along the lines of, are there things that can be done, medications that can be taken, procedures that can be performed that can prolong the ability to remain on active surveillance? Again, Dr. Pinto presented the ENACT trial. So again, along those similar lines in theme. And then in men with under 60, so a younger group of men with germline features such as DNA repair mutations or BRCA2 mutations, is standard surveillance equivalent to immediate definitive treatment, understanding that they are higher risk with a potentially more aggressive disease. And then the primary outcome would be cancer-specific mortality, secondary outcomes, quality of life, overall mortality or overall survival, those requiring progressing to definitive treatment and progression-free survival. That would be a longer period of time. And then this is all patients who have high-risk germline features who are being considered for active surveillance. Now, this can be a population to study because there's not routine testing, germline testing in a lot of these men. Even if it's indicated, it's not necessarily routinely performed. So this will need to be refined a little bit further. And then in men with newly diagnosed prostate cancer on surveillance, does either exercise with dietary changes, is that when compared to just a guideline summary or handout regarding diet or exercise, does that help with patient anxiety, adherence to surveillance versus withdrawal for surveillance, quality of life, and financial toxicity? Secondary endpoints being grade progression on subsequent biopsy and radiographic progression. Now, this was, I think, a very common theme amongst different sessions, that are there dietary or lifestyle or conservative measures that can be done for men on active surveillance. And we focused a little bit more on primary outcomes of anxiety or withdrawal from active surveillance, where patients can take control of their own care. But grade progression and other traditional metrics can be harder to study. Again, we'll discuss this in our small groups. And then in men with newly diagnosed prostate cancer on active surveillance, can the use of a beta blocker compared to placebo affect grade progression or radiographic progression? And again, this was along the themes of other things that can prolong a man's ability to stay on surveillance. And there is some preclinical mouse models and that have shown that there is some signal there. And this was, I think that Dr. Watts-Kara has actually done some work in this space, has looked at this space, so potentially a promising area. I'll turn it over to Dr. Putman.
Thanks, Arvind. So for my group, we were going to look at questions really related to the characterization of the tumor. So could we do something to better kind of risk stratify the tumor for appropriateness of surveillance? And the first, I think we have 5 that we were going to look at here. And the first 3 really kind of looked at imaging related kind of interventions or questions. Then we were looking at the utility of some of the tissue-based genomic prognostic signatures. And then lastly, we were going to look at approach to biopsy. So you can see the first one here is in patients undergoing surveillance, monitoring them and looking at them with a micro ultrasound. So this is a new high frequency ultrasound based technology. Would that be equivalent or better than doing it with the current standard of MRI and fusion directed biopsy? So we'll take a deeper dive into that in a small group. And then again, the outcome, what would be most appropriate there? Would it be progression based on some grade, reclassification, or are we going to be looking at more relevant endpoints like need for treatment or the need for a secondary treatment, if there was recurrence? And obviously we'll look at some financial toxicities. We gave a timeline of 5 years because we were looking at this both at the initial timing of diagnosis and whether they're appropriate for surveillance, and also the monitoring, which would take us closer to 5 years. And then the setting would really be places that would have a micro ultrasound. So there are some community places that have that too that we could incorporate. The next one was again looking at MRI, but we were looking at the role of contrast. There was some questions in our group previously about whether the contrast was really needed, especially considering that we're using MRI more serially, and that can lead in a lot. So the intervention would be looking at, a contrast MRI, is that equivalent to a non-contrast MRI, and the real outcome would be how many lesions or significant lesions do you fail to detect when you eliminate the contrast? And we would look at issues like MRI time, financial toxicity, again, this concern of brain toxicity for buildup of the gadolinium. I think we have 5 years, but I think we could probably do that in a shorter period. And this would be both in academic and community practice, any setting where they're doing MRIs. Next. We had another one looking at more of artificial intelligence and machine learning algorithms. We are seeing a lot more groups looking into this, and there's several groups looking into it in prostate. So the thought is, we know MRI of the prostate's not perfect, and could some sort of quantitative way of interpreting it improve on what we have now? And we wanted to see if that could happen both in a community setting and academic setting. And that would be the comparison there, is to see what the incremental benefit machine learning would be to MRI detection of cancer progression. And so the outcome again would be failure to detect significant lesion on the MRI that the machine learning approach would do, and misclassification of the lesion as 2 false positives. The timing, I guess we could also potentially do something in the 3 to 5 year range. And again, looking at any place that has the ability to roll out MRI with good technical standards, so academic and community. This one now steps away from imaging, and we're really looking at the utility of a genomic marker, so the tissue-based genomic prognostic markers for the most part, and we're looking at a more higher risk group, so intermediate favorable risk patients, and we're looking to see if a genomic testing on its own and how that would compare, let's say, to MRI fusion by itself and MRI fusion with the genomics. In terms of risk stratifying patients for surveillance versus immediate treatment. And so we would look at how this information would help with enrollment onto active surveillance protocols, and again, looking at reclassification as well, and timing of about 3 to 5 years. And I think we could do this, sorry, the settings out of there, but both academic and community centers where they're using this. And the last one just looks at an approach to biopsy. We had some discussion about, transperineal biopsies versus transrectal, especially with the serial biopsy, and avoid sepsis. And so we wanted to investigate that, looking at patient-reported outcomes related to pain, need to have revisits to the ED, anxiety, and then obviously looking at cancer detection and progression as well. We looked at timing range very similar to the others. And again, I think this could be done in academic and community settings. I think that was it for our group. And I'll pass it on to Christian.
Thank you, Sanoj. So Michael and I were involved in sessions, and then were tasked to put together some questions regarding intensity of follow-up on active surveillance. This is an important sort of day-to-day, week-to-week, month-to-month, year-to-year issue when you follow patients on a surveillance program. And I think designing studies is a little challenging to study this, but that was kind of the task, and we'll hopefully refine those. Next slide. So one possibility would be to take patients with prostate cancer newly enrolled on surveillance who have elevated baseline biomarker. You can pick your biomarker. We think that the baseline is probably the important biomarker, as these tend not to change very much over time on surveillance, with exceptions of, let's say, 10 years plus on surveillance. One could compare annual visits with a very strict surveillance schedule compared to annual visits with a more patient-specific surveillance schedule using available predictive tools, which is how many of us do our surveillance currently. It's a little patient-centric. Outcomes we thought should be adverse pathology, because if you were to look at grade progression, reclassification, or other parameters that could be affected by detection bias, you could really get a skewed result. Again, the concept would be if one group is getting biopsies more frequently than the other, you would have sort of increased monitoring and find things more early, despite the groups themselves being comparable, since we are randomized. So that was one concept of a study over, say, 5 years. Then we were, other groups looked at family history. So we thought, okay, what if we took men on surveillance with a positive family history, let's say with the Hopkins criteria for hereditary prostate cancer, which is fairly strict, or in addition, if a first-degree relative of the patient had died from or had high-grade prostate cancer, because we know from recent data that those are families where rare pathogenic mutations are more common. So you took a man with these predispositions known, and again, alternated between a strict and a more patient-specific surveillance schedule. Once again, to avoid detection or monitoring bias, we thought looking at adverse pathology over 5 years when patients chose or referred for surgical treatment would be the hardest outcome, perhaps, or the best outcome to compare. One could, of course, look at rates of progression to treatment and grade progression, et cetera. But again, that could be affected by intensity of surveillance. Other groups also discussed age. Obviously, men under 60 have a much longer time frame in which to worry about prostate cancer. They fortunately tend to have lower grade, lower stage disease than comparable men who are older, which has been shown by a variety of groups. So in these men, could we actually lower the intensity of surveillance? So this was randomizing a lower intensity strategy to a more standard patient-specific strategy. And the details can be left to discussion. And outcomes here could again be, what we discussed. Is it adverse pathology or need for adjuvant treatment? If we wait long enough, could it be biochemical recurrence? Again, trying to come up with outcomes not affected by as many biases as could be imagined. How to optimally integrate biopsy and PSA. So the population here is patients on surveillance. And this time the idea would be, could we compare an MRI intensive surveillance plan where we essentially try to use triggers like PSA or MRI and get frequent MRIs, maybe not every year, but that can be debated, to trigger biopsy. And there are MRI intensive programs out there and programs that use MRI as triggers to the more, again, standard, patient-specific surveillance plan that uses less intense imaging. And one could also imagine an MRI intensive plan versus like a PSA intensive plan. So, and the idea again here, since both plans are intensive, one could look at things like reclassification, i.e. upgrading rates, because the detection bias would be minimized, and secondary outcomes as well, over 5 years or more. Next slide. And again, this is a little more generic. Could we take a whole cohort of men on surveillance, multiple cohorts, and compare a low intensity surveillance plan with either standard or a high intensity surveillance plan? And then again, you'd be subjected to some detection bias issues. So you might have to look more at adverse pathology, but again, that could come up in small groups. What we thought would be a good outcome for that. Those were our discussions, and we'll discuss intensity of surveillance more in the small groups. Thank you.
Okay. And this last section here has to do with questions that are related to the impact of patient educational resources on either adaptation of or understanding of active surveillance. So one of the common themes that came up was sort of the initial encounter with the provider when your diagnosis is given to you. So the first question we came up with was men who are newly diagnosed with low-grade prostate cancer who would be candidates for active surveillance, and randomizing them to either a group clinic visit with the provider and maybe other men who are considering active surveillance versus just an individual clinic visit with the provider, and comparing that with just a solo visit with your provider. And we could look at rates of selection of active surveillance, the patient's level of understanding of what active surveillance is, as well as sort of decisional anxiety related to proceeding with that plan. And this could be accomplished within a few years of the initial diagnosis of prostate cancer. And I think pretty much any center that sees and treats men with this protocol would be eligible. Next. So one of the other common themes that came up in almost every session, regardless of the topic, was availability of information, educational and informational handouts or resources for patients to navigate and understand what active surveillance is and what the outcomes are and who's eligible and why. So we proposed a question for men who are newly diagnosed with prostate cancer that are suitable for active surveillance, and randomizing them to either give them an in-office instructional aid, perhaps like a decision aid that would be complementary to the clinic visit, and comparing that to patients who are randomized to undergo or be exposed to a telehealth or virtual standardized instructional decision aid that would be complementary to it. So two different forms of information and looking at similar outcomes, whether they are selecting active surveillance, what their level of understanding is, compliance, and their anxiety around their decision. And this could really be studied in most settings as well. Another question, again, came back to that initial visit with the provider to get your diagnosis and when you're making your decision as far as what you want to pursue for your treatment or your surveillance management. So new men who are diagnosed with prostate cancer are appropriate for surveillance, and looking at the difference between those who are meeting to receive their results in a multidisciplinary practice. So with providers from a variety of backgrounds, as opposed to with the single specialist visits, such as the urologist, with a second opinion from a skilled health educator. And then looking at, again, similar outcomes, uptake and adherence to active surveillance, and comfort and anxiety regarding active surveillance. So which of these resources or settings for sort of information delivery and counseling is going to be best received and most helpful for men who are deciding whether or not to choose active surveillance. And then these last slides are a similar question, but geared toward different populations depending on what our afternoon groups decide to focus on. So the first part of this is looking at all men, again, who are newly diagnosed with low-risk cancer who are on active surveillance, and looking at the development of either a national support group versus one at each site that's already available, which would be in person, and also having sort of interval access to a health educator, and comparing that to perhaps like a telemedicine support group, or even one that could be nationalized. Could also be compared to sort of some standardized literature. So the whole goal of this is looking at what are the support and resource modalities that are most helpful and most well received by men and potentially their support people in their lives for feeling comfortable and understanding, accepting, and mitigating anxiety around active surveillance. And this could be performed at most sites, but we were particularly interested in looking at this at academic sites compared to VA sites. So again, this is the same question with sort of formulations and variations within, but looking at it specifically in African-American or Black men who are newly diagnosed with low-risk cancer on active surveillance, and finding out which of these resources are most helpful. This is very poorly been studied to date and clearly came out of a lot of the discussions on Monday. So look forward to hearing feedback on this afternoon. And again, the other patient cohort we talked about and that came from the discussions on Monday is looking at this similar theme in men from a low socioeconomic status or low educational level with, who are deciding about active surveillance versus treatment, and finding out if one of these resources, support groups, health educators, or like a national telemedicine-based support group is going to be the most effective, most helpful at comprehension, anxiety, and adoption of active surveillance.
Wonderful. Thank you, everyone. So next, I'm going to hand over to Daniel Mullins, who will kind of take us through what the plan is for today.
Great. First, very exciting to think that in just one day, we were able to come up with such an awesome group of questions. And whether you were part of day one developing those questions or you're new to this today, I want to be clear that what you saw was a subset of some of the topics and questions that came out. We tried to really focus on ones that were patient-centered and could be put into the PCOTS format. But certainly we kept all the other information from day one. And after today, in fact, on tomorrow, we'll be sending out a survey where people can add additional questions. So up until now, we've been very broad. We've asked for patients and their caregivers, their family members, their providers to share broadly about their experiences. And now what we'd like to do is really try to take the set of questions that you just saw and get them into, a more nuanced fashion. So, if you look at the questions as they're written, how would you reframe them? So bring your experiences, whether you're a patient, whether you're a spouse, whether you're a community healthcare provider, a researcher, if you have multiple hats, bring that into these two breakout sessions. The first will be about taking these questions and trying to reframe them. And then the second breakout session will be talking about, given all of the amazing questions that we're looking at, how would you rank those? And again, this is the second day of a 2-day conference, but even after the second day, we're going to continue to raise questions and to continue to prioritize them. But we feel that your voices are needed to help us really get the best questions we can in these 2 days, and then to prioritize them. So with that, we're going to be going to that first breakout session. You'll be assigned to a room. You'll be given those questions that you just saw, the subset that you're assigned to, and we'll ask you to work with the moderators there to reframe and improve upon the questions that you've just seen presented.
You know, on the agenda, this is listed as closing remarks, but I really want to emphasize this. It's not quite closing remarks. I think that we're really talking about next steps, you know, that this was a first and very major step amongst many that we hope to make. You know, I think it's evident to everyone involved, the kind of the sheer power of like the collaboration and the bringing together of the people we have in the room. And there's a number of things we hope to do. Very concretely, we will be summarizing all of this information, and we will be putting together a report, and we will be disseminating the report to everyone who's registered for the conference. And so you should be able to access a summary of not just the top 8 questions that came up, although you'll be able to see that as well, but you will be able to see all 22 questions. You'll be able to see kind of our analysis of the things that were not generated into questions, but were clearly highlighted as very important topics. And there was a lot of that too. You know, some very important topics that we just couldn't capture as these questions, but still it's important to kind of maintain them as like areas of future interest and growth. Again, in terms of acknowledgements, you know, the conference was funded through PCORI. This would not have been possible without them, you know, through this Eugene Washington PCORI Engagement Award. So thank you to PCORI. Thank you to the Patients Program. Thank you to, I'm going to specifically name Andrel Metelier and Michelle Medeiros in particular, but there is a whole umbrella of people in the Patients Program, you know, led by Daniel Mullins, who really provided the infrastructure and backbone and some of the intellectual kind of structure of putting together something like this, and just a really talented group of individuals, and really helped this come together. The advisory board, these are people who've been involved with this project upwards of 2 years. You know, many of them you saw in your rooms today, you know, Tony Crispino, Joe Gallo, Arvin George, Daniel Mullins, Christian Pavlovic, you know, Peter Pinto, Chris Segal, Mike Scott, Judy Walensky. And so thank you to all these highly dedicated individuals. Many of these individuals, they simply not here because, you know, things evolve over 2 years. Carolyn Best has moved on to other opportunities and is playing very major roles and whatnot. Our collaborating partners, you know, ANCAN, ASPE, Prostate Cancer International, PCRI, Zero, Prostate Cancer, as well as AUA and Focal Therapy Society.
So like Minhaj, I would really like to thank the people at the program, the Patients Program at the University of Maryland, who did all the dirty work in the background with very little thanks from or nothing like enough thanks from me. I would like to thank Minhaj in particular for putting up with me being a real pain and pushing him to places that I think he probably wasn't very comfortable at the beginning. But above all, I would like to thank all of you. For me, this has been the real beginning of what I think could be a huge project. And I would encourage all the physicians who have given time to this and helped with this to talk to their colleagues and their peers about what happened here and how we can help to move it forward. I would hope that all of the support groups and all of the advocates will do the same to the rest of the patient community. And I would like to think that 4 years from now, we will have answers to a couple of these questions. It won't be all of them, but at least a couple we could probably get answers to in 4 years. And I would like to think that maybe a year from now, we have some sort of meeting again where we can say, okay, this is where we're at. This is what we've been able to move forward. And this is what we've had to change because we found a different way to do it or whatever. But I would like this to become a regular discussion between the physician community and the patient community as to how we move research into active surveillance forward over time. Thank you.
Yeah, I just want to thank everyone. You know, we started the first day by talking about the importance of getting the question right? When you get the question right, then the research can flow from that. So just thank you to everybody for spending hours making sure that we have the right questions. And yeah, a pleasure to work with Minhaj, a pleasure to work with Mike. And you've heard about this awesome patients program staff. I get to work with them every day, so they know how much I appreciate them. Thanks.
And we'll conclude with that. Thank you all.